Hello, everyone. This is Dr. Howard Kornfeld. I'm a board-certified emergency physician. I have been honored to, in the last several weeks, meet some of the top critical care specialists working on the front line of the COVID crisis. These are innovative doctors who have recognized that the standard protocols are not working. As we could see in New York, it's a disaster, and that disaster is coming to other cities. So I was thinking of asking Pierre Corey to maybe introduce the subject further to help explain why this incredibly powerful treatment, which all of you are providing, is not being provided, and how we can help change this situation very, very quickly.
Yes, when we talk about the therapy, I mean, there's a few therapies that we have in mind, but I would say like the core and the most powerful of them would be the use of corticosteroids in combination with intravenous ascorbic acid. This is, hospital grade, intravenously delivered, where we deliver it at relatively high doses, and we maintain those concentrations in the blood by giving it every 6 hours. And it works synergistically with the steroids, and we found many people have reported, I think all of us on this panel have published or done research or reported our results using those the two main drugs in combination in critical illness states, especially in severe infections and septic shock. But whenever you make a strong claim around a vitamin, I think most people, most doctors are very conservative and skeptical of such claims. And so it's very hard for most physicians to adopt the therapy fully. In critical care, we have achieved dramatic reductions in morbidity and mortality, largely around mechanical ventilation, judicious use of fluids and different antibacterials. And we have these great outcomes. But here comes COVID. And what's happening here is the crisis is that I think we're not starting effective treatments early enough and aggressively enough. And as a result of that failure, our ICUs are filling, our ventilators are running out. We're now forced to devise these ingenious ways of splitting ventilators to ventilate multiple patients. And one of the core principles of critical care that we might be forgetting is that time is of the essence. You need that we call it the golden hour of resuscitation. So as soon as someone falls ill, that's when the interventions need to be started. And I think the answer is actually not in the ICUs. I think by the time they get to doctors like us on this panel, we're going to struggle, even with the powers that we have with these therapies working synergistically. My appeal is to the doctors out on the front lines, the doctors who are first laying eyeballs on them in the wards, that we have to change our strategy here. It's not working.
So just a few points with reference to COVID. So I think it's really important to treat patients for the disease they have and not for the disease we want to give them or we think they have. So there are really three fundamental concepts. Firstly, this is not typical ARDS. And if you intubate them early and put them on a ventilator, you're going to damage their lungs. You're going to harm them. Number two, this is a profound hyper-inflammatory state. They have these ground glass opacities, which is inflammation, not fluid. And you need to give anti-inflammatory drugs. This is not the virus that's hurting the host. It's the acute inflammatory dysregulated response. That's why you need to use vitamin C and steroids. Steroids play a critical role in the synergy between vitamin C. The third point is these patients come in with a profound hypercoagulable state, which is somewhat unique to COVID. So we believe that you need to anticoagulate them up front. And indeed, if you look at the Shanghai guideline, they did two things or three things. I mean, it's a truly remarkable, and I didn't appreciate it when I first read it. They gave heparin, they gave vitamin C, and they gave steroids. So that's the first point. The second is you need to treat these people early as I think Dr. Varone and Dr. Corey and Dr. Iglesias will reinforce. If you wait for them to crash and you wait for them to land up on a ventilator, the Titanic is already sinking. You have to intervene early and aggressively to prevent them deteriorating. And in this way, you can prevent them landing up on the ventilator, which is actually harmful.
Having seen what vitamin C could do, I decided to start giving vitamin C very early. So let's say you are a patient that comes to me with shortness of breath and an abnormal CT scan, like the ones that has circulated among some of us. I mean, that is the moment when I put you in my intermediate unit and I start you on the cocktail. And we've had several variations of what we have done for the cocktail, but I have not had a single death, not one death. And I'm getting slammed with 4 to 5 admissions to the unit minimum. So, you don't need to sell me the vitamin C thing. I know it works.
Yeah, what I'm hearing is that in these 24 patients, using Dr. Merrick's protocol, essentially, with some variation, you have had no deaths. Is that correct?
That's exactly what I'm saying.
Yeah.
If you started early, your patients will not even need to be intubated.
Vitamin C had a profound effect, and clearly there's a synergistic effect with the use of corticosteroids. Therapy early is of the utmost importance. This is these patients start getting very inflamed by about 5 or 6, and because the ERs are already congested, they're coming in at that time period to where the point they're going to get that subgroup of patients, that endotype of patients that has that coagulopathic and inflammatory response is going to be there, and then probably earlier treatment is when you're going to start seeing a better effect.
The corticosteroids work in viral pneumonia. While there are 2 large studies in patients with SARS, more than 5,000 patients, and there is another large study in patients with A1N1, all from the Chinese literature, indicating that the use of methylprednisolone, that is the one recommended by the task force of the Society of Critical Care Medicine, Intensive Care Medicine from Europe, is associated with a significant reduction. The reduction in mortality was 50%. The protocol for steroids has been recommended by the Chinese, Korean, Japanese, and Italian society. So it is already a part of the guidelines there.
The point that all the physicians are making is really early treatment. A lot of the thoughts before was to start once they get to the ICU, but what we're now finding, because the ICUs are now being overwhelmed, is to start as soon as they come into the emergency room. As soon as they're identified with COVID-19, able to start that treatment within that first 6-hour time window, we can prevent a lot of these people from ending up in the ICUs. Know that we're actually down to less than 15% capacity for ICU beds in New York City.
When we talk about early treatment, we have to recognize that many centers around the country have long turnaround times for tests. I would say in any high clinical suspicion of COVID, it should be started. What it really is a life-saving therapy.
That's it.
And it's actually been proven to be life-saving in the condition that is killing the world. The condition called acute respiratory distress syndrome. The patients are dying of overwhelming inflammation. We need to marshal our therapies that are directed at suppressing that inflammation. It's key to keeping these patients alive.
I think that the patients coming in already to the ER have selected themselves out in one major direction, particularly if they have pulmonary findings. They are clearly most likely of a pro-inflammatory and coagulopathic genetic endotype, that a large percentage of them will end up very ill very quickly. They've already been at home sick for several days. So they're already at that time point where they're at that kind of hill before they go downhill. And that's when we should treat them from the emergency room.
So the common denominator in these 5 physicians who are at the front lines, critical care units, watching or actually ordering the drugs themselves, is that intravenous vitamin C, intravenous ascorbic acid, along with corticosteroids, given at the right time, not for mild illness, This is for when the oxygen is dropping, the virus is essentially taking over the lungs, a massive inflammatory response is occurring, and it needs to be done extremely expeditiously within hours, if possible, of presentation to emergency rooms. This, as far as we understand, is not what's being done in a widespread way yet in the United States.
I think patients are dying needlessly, and I think this is a terrible shame that we're allowing this to happen. It is an outright shame. We have effective therapies that can alter the course of the disease. We need to institute them early, aggressively, and we need to prevent patients deteriorating and landing on a ventilator. Once they land on a ventilator, we know their course is prolonged. The mortality may be up to 60 to 70%. It takes them a long time to get off the ventilator, and we really have no idea of their functional capacity once they get off the ventilator. We have to do everything in our power to aggressively treat them to prevent them going onto the mechanical ventilator.
People that are presenting to the hospital are already a group of sickest patients. Remember, 80+% are being treated at home. So it's that 20% or even maybe even less that are sickest. So that's why it's so important to treat early. They've already been self-selected out to be the sickest of the patients being infected with COVID-19.